I hope to share with you over the next hour a little bit of advocacy, because this is a group that could make a huge difference. I spent a good deal of time in 2015, 16, and 17 in Washington, D.C., and that's how I fell in love and decided to convince my husband to move here because of the impact that policy can make. But policy has to be evidence-based, and what I want to talk to you about this morning is what the gaps are in the evidentiary base that could influence policies that improve health disparities. So just to get an overview of what I'd like to do this morning, I'm going to get us sort of on the same page in terms of what I talk about and mean when I say disparities. Because I'm trained as a lawyer and then as a researcher, I think about disparities in terms of injustice. I think about them in terms that I'd like to help us level set and define together. After that, I will look at some small sample of the evidence of healthcare disparities, and then I'm going to shift and suggest that's not where the action is, if you will. Healthcare disparities are significant, serious, persistent. They are improving. But I'd like to suggest that the real issue is in disparities with respect to the social determinants of health, and we have real research gaps in those areas. So I hope that this is an audience that will be open to talking about research gaps with respect to the social determinants, and then I'll give you a case study of a research project that I think could be an exemplar for the kind of information we have, and more importantly, the kind of information we still lack. And then I'll conclude. So when I talk about health disparities, the evidentiary base began to be compiled in a way that was public and comprehensive by a National Academies of Medicine report that was published in 2002, 2003. And it looked, how many of you are familiar with unequal treatment? It looked at disparities in terms of documenting them and the multi-level sources of those disparities. And of course, we have updated since 2002, 2003 annually a literature that is becoming copious. Now, the report I look to each year just to get a snapshot, that is a summary of how we're doing on healthcare and health outcomes disparities, is a report that's done by AHRQ, and it's actually congressionally mandated. I think it will be done next year, although it's not altogether clear that it will be done next year. But it's based on 250 measures of quality and access disparities. And let's just look at a snapshot. How many of you are familiar with the AHRQ report and have seen it? So it shows sort of in a summary fashion. These are the measures with respect to access to care and disparities by race, by ethnicity, by socioeconomic status. They don't do gender, they don't do disability, they don't do LGBTQ or sexual orientation. There's a research gap in the information we have as to the status in those categories. But as you can see from this slide, access to care is generally not improving. Insurance status is improving, and this period is from 2000 to 2016. Some of the measures are 2014, but this is the 2016 report. However, we can see that by quality measures, patient safety focus, care coordination focus, we are seeing some improvement with respect to racial, ethnic disparities. And again, the omitted categories aren't shown here and aren't collected easily. However, some of the persistent disparities are particularly concerning. Now, as I said, I'm trained as a lawyer, and so I look more closely at what we call protected classes. That is, disparities in health outcomes in populations that I can actually address legally. I can actually do something about. Race disparities, gender disparities. Legally, there's no cause of action, there is no regulatory remedy for disparities with respect to socioeconomic status. That doesn't mean they're not important to me and generally, but you won't see much of that data in my slides. We can talk about it in the Q&A if that's of interest to you. But let's look for a second at infant mortality. I'm going to give you 4 exemplars just to understand and level set what I mean by injustice and inequity, which is what I call health disparities. So in the United States, the best evidence right now is that Black mothers lose their babies approximately 2.5 times as frequently as white babies in the first year of life. And that's true whether we control for socioeconomic status. It's true when we control for educational attainment. So in the state that I just came from, as you heard in the introduction, Colorado, we find that a white mother who is below the poverty line and has obtained only an 8th grade education actually has a 2 times better likelihood of her child passing age 1 than a Black mother or a Latino mother who has a college education and a $50,000 to $75,000 income. Another category that we are seeing a tremendous number of or gaps in disparities is in maternal mortality. And of course, this is a picture of Serena Williams and her child, so this got lots of prominence. New York Times did a special on it. And so we know that in the United States of America in 2018, African American mothers are likely to lose their lives in childbirth, 3.5 times more likely to lose their lives in childbirth than white mothers are. And so these are exemplars, if you will. We could literally do this all day. This slide is from the Kaiser Foundation, and it talks about health disparities in 3 disease categories. And you see that by race and ethnicities, there are differences, dramatic differences with respect to HIV/AIDS, mental health. But in a very perverse way, stick with me on this if you will, in a very perverse way, I am encouraged by the tragedy we are experiencing in the opioid crisis, because those disparities have the reverse with respect to race and ethnicity. We see in this slide the disparate incidence of overdose deaths by race. And in fact, of course, we're all familiar with the very prominently discussed data that this, along with other deaths of despair, suicide, alcohol-related deaths, opioid overdoses, is actually bending the life expectancy curve in the United States. Now, why do I say I'm perversely encouraged by this? Again, please stick with me. What I think this is showing is that some of the very complicated stories about health disparities are true no matter what the color of your skin is, right? So when we talk about deaths of despair, what I'm going to be focusing on ultimately is social context in which people live, work, play, eat, and die. Those social contexts, if they are equally despairing, then race will not be the only thing that defines the probability and likelihood of death and the outcomes. Why is this encouraging? In the Black community, we say, oh, now that the problems have hit the white community, maybe they'll get attention. And I know that's a really rough thing to say in the morning. I'm sort of a rough early morning speaker. But I'm still a nice person. These things are true, right? So when you see this kind of data, we're thinking, maybe the circumstances that have hit underserved and underrepresented minority communities and are now hitting white communities will get attention because they're not the other folks' problems anymore, right? So where are some of the research gaps before I go specifically to the area I want to linger with? Let's talk about participation in research, clinical trials, right? And some of the data is really concerning given the prevalence. I'm just using here data from recent clinical trials from the National Cancer Institute. So this study shows that the disparities in racial and ethnic minorities participating in clinical trials through the National Clinical Trials Network, which did studies huge studies on breast, lung, prostate, and colorectal cancers are narrowing, but the key here is that underrepresented racial and ethnic minorities groups don't have access to these clinical trials. Moreover, the research design that is addressing populations that carry the greatest burden of disease is not being represented. Recently, it's been found that Hispanic and Black populations are underrepresented in all of these groups. A study of lung cancer that had over 56,000 participants had fewer than 10% of those participants be representatives of underrepresented minority groups. Big data is also similarly burdened. Alice Popejoy wrote an article in Nature that highlighted the fact that the genomic research gaps are huge, even though they were found to be narrowing, so that now 81% of all studies done on people using the genomic studies genomic studies warehouse material is done on people of European ancestry. The remaining 18% is largely done on Asians. And as you can see on the left, I really highly recommend Alice Popejoy's article to you in Nature magazine. It was followed up by Latrice Landry's article in Health Affairs in 2018. Underrepresented minorities are not getting access to the precision medicine revolution that's occurring because we're not being represented in big data sets. Another significant gap is on my mind because I had a front and center seat in Charlottesville, Virginia. I started at the University of Virginia on August 10th. So my welcome committee was from the KKK and the alt-right. The impact of racism, racial violence, and the stress of discrimination is understudied. And hopefully we're going to begin to address that, but it needs to be addressed around the country, multi-site, large studies. One of the real gaps in study is understanding epigenetics, understanding why and how I carry inferior ability to fight disease because my mother lived through Jim Crow. And the young women of childbearing ages that lived through August 10th and 11th, and still to this day, I mean, I can attest to it. I lock my door, I look over my shoulders when I commute between DC and Charlottesville. I make sure that my gas is full, my phone is charged, and I don't have to stop. Why? Because I'm a little bit scared all the time, right? And so the impact of these racial factors, discrimination, is understudied and underappreciated. So research gaps, the last one I want to land on, and here's where I want to linger. Research gaps are vast with respect to social determinants of health. And this is just some data to bring home the connection between the lack of research and the lack of policy. Like I said, not only did I have this front and center seat in Charlottesville, but the last year I spent in DC on Capitol Hill was in Senator Stabenow's office, and I got there a month before the emergency was declared in Flint with respect to water. And so I got to see how there is an intense need for an evidentiary base. You talk about evidence-based medicine. I'd like to talk about evidence-based lawmaking. But one of the things we see in this Elizabeth Bradley study, published in Health Affairs, and she did 2 amazing studies. This one shows that the ratio of medical spending to social spending in states is directly related to health outcomes. And why is social spending so low? I submit to you, and the takeaway point I'd like to leave with you today, if nothing else, that is this. One of the reasons that policy with respect to social spending is so low is because we, as policymakers, as lawmakers, don't have the evidence from research to tell us what an adverse impact that has on population health. We don't have the data to understand the return on an investment, to be totally crass, right? To understand what an economic difference it would make to states and to federal budgets, particularly state budgets in this environment. This is where the action is right now with respect to health policy. We don't have the data to show us that the cost of delivering health care would actually be reduced if we increased our investment in social spending. So now I want to turn to social determinants research, which is what I want to look at. So how many of you are familiar with this social determinants graph? Okay, so if it is the case that only 10% of health outcomes are determined by health care and access to health care, I'd like to encourage a conversation that increases the amount of research attention that's being paid to the social context in which people are living, working, and playing, the causes of the causes, right? That was the import and the meaning of the segue slide showing you Elizabeth Bradley's study in all 50 states, right? So how would this look? I'm just going to give you an example of one study in the area of medical legal partnerships, which is where I work. And it's about a patient population. I'll start off with a story with this child, baby Eduardo. So baby Eduardo comes to my medical legal partnership, and before I go on, how many of you know what a medical legal partnership is? Oh, not enough. Okay, so I'm going to have to linger for a second longer and tell you about that. Medical legal partnerships are exactly what they sound like. They are opportunities where health delivery is modified by embedding a lawyer into the health delivery team. And of course, that doesn't seem like a natural ancillary service, right? And so I've got to do some proof of concept here, and that's what this study is about, right? In order to say that when a lawyer is embedded into a health delivery team, particularly in a primary care setting. So this is a study that was done on 31,000 patients in a primary care clinic, actually three primary care clinics in a children's hospital in Colorado, right? But the model has actually proliferated all over the United States since 1993. It began in Boston, where legal aid societies began inserting lawyers in primary care. The uptake was greatest initially in children's hospitals and in federally qualified health clinics, right? So when you talk about integrated care, you usually talk about primary care and behavioral health. Super important, I'm all over that, I agree. And if you're really forward-thinking, you talk about primary care, behavioral health, and maybe oral health. We'd like to talk about primary care, behavioral health, oral health, and social determinants. Medical legal partnerships are one of the really forward-thinking ways in which inserting a lawyer can address the social determinants of health. So here's an example. Baby Eduardo is born in Colorado at the Children's Hospital of Colorado, and he's got a congenital defect, a respiratory defect, that requires him to live with a trach until age 3, when he's anatomically mature enough to have an operation that removes the trach and he has a normal life from a health perspective. He comes to our medical legal partnership. Why? Because his parents are about to be evicted, right? And so it was a legal problem that brought his health issue to us. But even more than that, hang with me, because the theory of medical legal partnerships is that legal problems have health impact. There are health-harming legal problems. In other words, problems that if you don't solve those legal problems, you're actually not going to get a better health outcome. And so baby Eduardo comes to us because his family is being evicted. Why are they being evicted? Because mom is pregnant, Eduardo has a home health nurse, and as you can imagine, a lot of medical paraphernalia. They live in a second-floor studio apartment, and they've asked the landlord for permission to move to a one-bedroom apartment to accommodate now a growing family and his medical equipment. But because baby Eduardo's father is out of status, which is what we call undocumented immigrants, because I can get a lot of people that people call undocumented into status legally, which changes the health care access completely. But because baby Eduardo's dad is out of status, they get threatened with an eviction, their rent is raised, and this is what I call injustice, right? So I'm coming in with my student team to address an eviction problem that is intimately tied to his health outcomes And I find 4 other legal problems that are relevant to his health also. 1, Dad is undocumented. And so his work life looks like this. He gets up in the morning, he goes out to a certain corner in Denver, Colorado, and he seeks somebody to come pick him up, for day work as a day laborer. People pick him up, he goes and works a full day either in construction, in agriculture, he gets dropped off, and it's a 50-50 shot whether he actually gets paid. And he has no recourse because he's undocumented, right? So they want to know, can I get Dad into status? And can I do something about the employment immigration? Fast forward, I couldn't. I couldn't get Dad into status. I got Mom into status. That was problem number 3, right? And problem number 4, of course, is their housing eviction. And I will say, the story ends really well. Okay? So there's baby Eduardo, and let me tell you what I had to try and figure out. I had to try and figure out how many of those legal problems had a health impact, and let me suggest a host of them did. So I used this photograph from Flight 1549, that flight that landed on the Hudson River because it ran into a gaggle of geese. I used this to demonstrate why medical legal partnerships work and why it's so important to do research on the social determinants. So does anybody see a difference between the 2 populations in this plane? This is an actual picture of the plane that landed, Flight 1549. And you see that of the 155 souls on board, they're all now outside of the plane. Talk back to me. Anybody see any difference? People in the front, people in the back? Yeah, right, exactly. Somebody yelled life jackets. So if you're in first class on Flight 1549, you've got a lifeboat, a life jacket. There are far fewer of you. You've got flares. You've got a box with some food rations. And if you've got to stay in the chilly Hudson in January, your life chances are way better than the people who are on the back of the plane in coach, standing on the wing as the plane sinks, right? All 155 souls got saved. That's why this is a good slide for me to use. Because what I can say to you is I really am not advocating that everybody gets first-class service. I'm not advocating that everybody gets linen napkins and drinks before we take off and early boarding. But I am advocating that all 155 souls, as in this instance, deserve to be saved, right? They deserve not to die in the chilly Hudson River. And so the message to take away from this slide is that place matters. Place matters to your health, place matters to your life chances, place matters to your educational attainment. It matters to your educational opportunity, and it mattered to baby Eduardo. So how much did it matter to have this medical legal partnership intervene on health-harming issues that had to do with housing? And it's not just housing that we do. Baby Eduardo is the housing example. That's the real. Immigration, domestic violence, educational discrimination by disability, access to equity with respect to police enforcement and criminal justice enforcement. All of these are issues which have an impact on health, but we don't know how much. Right, so when I set up one of the 300 medical legal partnerships, I just moved from the University of Colorado to the University of Virginia. We're setting up a medical legal partnership in Virginia. And the question is, of all of the legal services that we can offer in the start, right, we can tell you all the demographics of our population, we can tell you the patient flow, we can tell you all of their information, but I don't know which legal service to start with for the most bang for the buck, right? So I'm guessing. I'm guessing that housing is first. But if you look at the literature, it's not just eviction, but it's housing conditions. There's an intimate relationship between the quality or standard of housing, whether I have utilities, whether there's lead paint in my walls, whether there are allergens in the carpet, whether there are structural unsafe conditions. All of that relates to health by population, but I don't know by how much. I don't know whether to work on that or work on affordability. I do have data that tells me when a family pays between 30 and 50% of their income or more on housing, they're not spending on health care, they're not spending on transportation, and they're not spending on food, especially if they have children, they're not spending on food, right? It doesn't take a genius to know that that's going to have a health impact. I don't know by how much. So when I set up this medical legal partnership in order to address baby Eduardo's or the likely similar children, what I'm seeking to do is disrupt what's called the social gradient, right? I'm seeking to disrupt the natural relationship, and Sir Michael Marmot, is the real grandfather of this literature. But the social gradient says inevitably there's a direct and linear relationship between poverty, race, and poor health outcomes. I can disrupt that to the extent that the mechanisms are social determinants of health, and the extent is substantial, it's non-trivial. But I don't know how much. So I'm trying to figure out the answer to this question with a study that looks at, and this is just now my example of how we might look at this. This is one study. It's one of the better ones, I will say, in the medical legal partnership literature, but there are serious shortcomings to the study. One of the first shortcomings that you could fix is that I'm only looking at observational data retrospectively. The number of random clinical trials on social determinants issues is negligible, right? And yet, remember that pie chart, 40% of health outcomes is determined by social context, and I don't have the data to tell me about it. So this study, its specific aims were essentially to try and figure out how this intervention aimed at housing, immigration status, was going to affect the health outcomes of the population, because those were the two things. We did housing, access to public benefits, and immigration status, right? So we had 4 outcomes of interest. One of them were hospital inpatient stays, just the number of days hospital inpatient stays. The second one was an attempt to get a proxy for access to preventive care. So number of missed doctor's appointments, number of appointments made, number of appointments canceled, number of appointments missed, right? We looked at immunization compliance as another way to get at this access to primary care. Because it's so easy to tell whether a kid is coming in at 2, 4, 6, 18 months, the recommended schedule for immunizations is a great way to tell whether a kid is coming in, and we thought we could tell by that health access what their ultimate life course chances were going to be if we looked at immunization compliance. And then there was a 4th outcome of interest, and that was looking at a social factor, residential stability. And that was based on the very strong literature that a child that is residentially stable in their early lives is healthier than a child who is unstable, and the accompanying literature that also tells us that if a child is upwardly mobile, if a family gets to move to a resource-richer, this is Move to Opportunity, Raj Chetty's work, a resource-richer neighborhood, then that child has better schools, better social networks, and better life course chances. Again, place matters. Remember the airplane. So those were the 4 outcomes of interest. We did basically a propensity study because, as I said, it was retrospective data, and we were looking at that data, observational data. So the propensity study essentially said, we don't have a control group prospectively. How are we going to pick a group of people that look as much like the people who actually got the treatment? There were 1,077 patients that actually got the treatment. And as I said, 31,000 patients in the data set. So what we did with the propensity matching, and a lot of social scientists are using it, again, not a perfect methodology to infer causality, but what a lot of social sciences are doing, and this is what we did in the study, we basically looked at pre-treatment covariates and found as many of the 202 that we gathered that could help us come up with a propensity score that said the people in this group we created, the control group, are as much like the group that got treated as possible, so that any remaining differences could be attributed to the intervention, the medical legal partnership, right? We also did a pre-post analysis, and we also did qualitative analysis, that is interviews with the patient population groups that got served, 8 sample groups and their families. And also we had access to the legal records for those patients that became clients of the Denver Legal Aid Society. So it was a mixed method study, and these were the things that we looked at. One of the things we were really interested in, and again, this we had to look at because this was our best guess, was what difference it made with respect to health outcomes of interest if the intensity of the legal services increased. And again, I'm flying blind here. This is not an optimal way to try and figure out whether I'm actually making a difference in these 300 and growing medical legal partnerships, but we wanted to see if all I did was a consultation, something that you and I can do easily. If you have a legal problem, let's say you have a tax problem, either you know a lawyer or you know somebody who knows a lawyer, you pick up a phone, you get that consultation, your stress level with respect to that legal issue is lessened. People who are vulnerable don't have that, so we thought, okay, just the consultation probably is going to have an impact, but does it make any difference if that consultation turns into a letter? Baby Eduardo's family got a letter, for example. Letterhead, law school at the University of Colorado, signed, Esquire. I have to tell you the end. So, dear landlord, it's come to our attention that Baby Eduardo's family is being evicted. And we understand that this eviction is not following section code number XYZ in Colorado. And we understand furthermore, because you are an immigrant serving development, that we might be able to find many other families that are suffering excess rent and unjust eviction. Baby Eduardo's family got a 2-bedroom apartment and a rent reduction the next month, right? So that's a happy, easy outcome. It doesn't always happen that way. We had a family, for example, that was in a literally rat and bed bug infested trailer. I knocked on the door for my first intake, right? You don't have any reason to know this about me, but when I started this work, I was not a poverty lawyer, right? My firms that I worked for were always 400 lawyers and bigger, right? So I'm coming out the, justice queen. I'm coming to set things right. I knock on the door, and the call from inside this trailer park is, stand back. I say, stand back. Okay, I'll stand back. And I was dressed for success, because that's what a lawyer is taught to do. I stand back. My client comes to the door, opens the door, and a literal shower curtain of bed bugs falls down. I know, kind of gross. And he says, come in. I'm going to tell you, that was, the story gets worse. But anyway, so back to the study. So the result of the study, really quickly, we found that we had a correlation, an association between reduced number of inpatient hospital stays and the presence of a medical legal partnership. Where the real money was 98% reduction in the number of missed appointments once you get a medical legal partnership. And I'll tell you, that was also confirmed in our qualitative interviews, and I'll tell you a little bit more about the bed bug family just to tell you that. That was a family of 3. I could spend the rest of the day because they were such a triumphant story for us, right? What we ended up with was a family who had missed all of their appointments, was paying $725 for that trailer that I described. I did go inside. I burned my clothes afterwards, I will be honest with you. But I did go inside. They had no plumbing, and they were all suffering depression. I go at 1 o'clock in the afternoon, and their 22-year-old son has to be roused out of bed to sit down and do an intake with me, right? However, this data is enriched by the interview we did with this family after a group of 6 students, and it was students, on a below zero day, came having arranged for some extermination services. They washed all of their hard things that were their property in alcohol, put them in storage, moved them into a 2-bedroom apartment because we got the trailer condemned, right? So they could move immediately. They didn't have to wait the 6 years in Colorado for new Section 8 housing because we were able to condemn the trailer. This is a great story. It's a great outcome. It's a great feel-good story. It is one family. no matter how wonderful that is, it is just one family. And what we need are structural changes. And we need the research and the evidence to go to policymakers and to say 6 years won't work. It's too costly for populations from a health perspective to stay in the kind of housing that we got this one family out of. It is too costly in terms of missed appointments and failed access to care. So let me finish this study in Baby Eduardo's study. Immunization compliance, no change. That did not work, and I'd be glad to talk about why that outcome did not work. It was a real disappointment because that was one I was really banking on, but I have a lot of reasons why I wouldn't want to stop. I want to try that. I want somebody else to try that. I want that to continue. And we didn't see a real significant change. The residential mobility, upward instability, all of those variables, they're too attenuated. I don't want you to keep studying those. That was a bad research design. All the p-values there are pretty depressing, so we're not looking at that. But the qualitative interviews, oh my goodness, they are so revealing in terms of research gaps. Again, I talked about the stress of racism. The stress of being poor is health harming. Poverty is a killer. So the number of people that told us that the difference between having a lawyer and not having a lawyer, of knowing whether or not they have a protective order against the person who is physically abusing them and not knowing, is a health game changer, right? But here was the problem. Of the 150 cases that I had actual legal files for, over 12% of them did an intake, identified a problem that was connected to health harm, and didn't have a lawyer. They just didn't have the capacity. And that's a policy problem. With better data, I can go to Congress, maybe a different Congress, but I can go to a future Congress, and I can say, this funding is important, not just because we want you to care about the humanity of the people who are suffering. That would be nice. Not just because of the injustice and the stain and mark it is on our country's values. That would be nice, but because it's costing our society money. But I need the data. I need the evidence to be able to do that. But what we have so far, I could go to the legislature in Colorado and I could say that you should fund Medicaid waivers to cover medical legal partnerships and social workers to address the social determinants of health, because I can get you a decrease in the number of, and our data was great on inpatient hospital stays, emergency visits, and so I can do a great job of getting people out of the hospital and make sure they go into the right hospital portal, and I can do a better job of getting Colorado, its objective was to be the healthiest state in the country, right? I moved to Virginia, what was their objective? To be the healthiest state in the country. Okay. But if those are your policy objectives with the right data, I can show you how to do this. Now, I said the outcome for Baby Eduardo was also really good. Not only did he get the 2-bedroom apartment, but because, again, the students were amazing, they were able to find a complex owned by a man who was formerly out of status and had a heart for families that were out of status. And he got them a 2-bedroom apartment. Baby Eduardo got his trach out. As I said, I got mom into status. We got mom into status. We didn't get dad into status. He's lost to follow-up, and that's almost by choice, right? But Baby Eduardo, a citizen of the United States of America, now has a shot at health equity, right? So my conclusion is this: policy does depend on good evidence, right? The study I did was an attempt to show how we can make a difference in making an argument for Medicaid expansion, for health payment reform, so that the social determinants are covered by a reimbursement structure that doesn't disappear episodically, and for health delivery reform. We could change health delivery reform with the right data. What we're looking for, this is my last takeaway message for you, what we're looking for is actually health equities. I would like to expand the conversation about disparities, which is just limited to the unjust and inexplainable, non-clinically supportable differences in health outcomes. I'd like to talk about having an equal access to the opportunity to be healthy for all, no matter what your gender, your sexual orientation is, no matter what your disability status is, no matter what your race or your ethnicity is. I'd like the conversation to embrace all of the factors that affect health equity. And that's really a public health frame. That's why I show the Broad Street pump. The more public health data and research we have, the less inequality, injustice, and inhumanity we'll have. Thank you.
So we certainly struggle with trying to think of measures for social determinants of health research and an evaluation. And I was excited initially by your quantitative measures that I thought, oh, this is great. We're going to write this down. We're going to follow these. And unfortunately, you sped through. So when you reflected on the measures you chose, did you come up with any other measures you wish you had chosen that you thought might be more encouraging?
Yeah, certainly. Measures with respect to utilization are great because they also are attached to cost. So the inpatient hospital stays, that worked. So emergency room visits is great. Any utilization of anything we can actually cost is a really good outcome measure. I'm going to stick with immunization and other types of long-term life course interventions because the reason our immunization measure did not work is because our population was too young. Our population we only did from 0 to 3 years of age. That's too young, and we did that in part because the data drops off so badly after age 6. But if we had at least gone to age 6, number one, and number two, if we had more jurisdictions than Colorado. Colorado is a quirky jurisdiction. Because of the fact that there are so many people who opt out, sort of the anti-vaccination movement, it's very powerful in Colorado. So yeah, it's crazy. But that was the database that I was dealing with. So I actually think immunization compliance is really powerful. BMI does not work, don't bother. We did that for a while, and obesity measures did. So health status, not so good, right? Anything with respect to utilization, very good. And then the story, also the logic model is easy to tell from that. So those are the things I can say about that much.
I'm Michelle Graver. I'm the acting director for Utopian in Canada, a PBRN. Would it help if we had more collaborative studies between the US and Canada? We'd be very interested and very keen to work with our colleagues in the US on that. There's differences between systems. We have our issues. You have different issues. Yeah. How do we do that? How do we increase the number, the quality for this really key topic? Yeah. Do you have any thoughts about that?
I do. I have one thought. I think it would be brilliant, and part of the reason it would be brilliant is because access is given so much play. I mean, we're all arguing about the Affordable Care Act. I think it's a great statute. I think we should keep it. I really strongly support, and you should call your congressperson to tell them that we shouldn't dismantle coverage for pre-existing conditions. All of that's great, but really at the end of the day, that is a statute that is mostly about access. If we were collaborating with Canadians, we could be able to say, some of this is not about access at all, right? A lot of the disparities, of the inequities that we're talking about have not to do with access to care, but they may have to do with the quality of care that is obtained after access is universal, right? When you saw the earlier ARC slides that I was talking about, the access numbers are not improving greatly, but they're improving over time, and yet our health outcomes are terrible, right? Maternal health gaps are widening. They were 34, 35% in 2007. They're 48% now in 2015. Wrong direction. And that's not because Serena Williams doesn't have access to care. Something else is at play. So I think the collaboration would be great.
You mentioned a few times the involvement of students in the medical legal partnership, and I was just wondering what models have been developed that may not involve students if you're in a community or a setting where a law school or access to students may not be available.
Yeah, I favor the models that involve students only because I'm a teacher, but in terms of scaling up the model, I don't favor student models at all, right? Because what, I get 6, 7, 10, max 12 students a year, and so I can help 12 families. Let's say all my outcomes are really good, and the loss-win ratio is very high once you get a lawyer in here. But the model that is preferable, I think, are two. One, if legal aid or the LCS organization in your state or locality is funded adequately, those people are absolute experts at poverty law, right? So we don't have to pick and choose as to whether we'll do domestic violence or public benefits. They do the whole range, and they don't get squirmish when they knock on the door and bed bugs come out, right? Because they are true experts. So legal aid organizations that are actually under the 21st Century Cures Act getting a little bit more money, but not enough to have the capacity that's needed, that's one model. A second model is embedding attorneys into a health plan or healthcare network organization. Centura has done this, Centura Health in Colorado, and for that you really have to make the value proposition or the business case clear to the health provider. How much, and this is where I think the ROI, the return on investment evidence, is the best, how much better are your collections going to be if you have a lawyer? Right? We're going to do a great job of making sure all the coverage reimbursements that you are entitled to. Now, on the side, we'll also address domestic violence, right? We'll also just address the stress of discrimination in employment. But when you can embed a lawyer into the delivery team in the institution, the only way that's going to happen on a scalable level is if we really do change the value-based payment structure.
Hi, I'm Denise Campbell-Sherr from the University of Alberta in Canada. Yeah, I don't know where to start with questions. I have about like 20, but the one that struck me that was kind of interesting was the pie graph that you showed where you had the 40%, but then you had 30% on health behaviors.
Okay.
And it strikes me that often those are two, they go hand in glove, right? Because as you point out, these folks are distressed, there's depression, that's really entwined with their lived reality, their circumstances. And the circumstances in which they find themselves means that some of these behaviors are manifest in different proportions, right? And so they seem very entwined. And I'm curious in your work, and I'm an obesity researcher, so we could talk a long time about why you wouldn't see those as being outcomes. but I'm
I do see them as outcomes. I don't mean to be disrespectful, but it's hard to do it's hard to infer causality.
Yeah. So I'm just curious about, in terms of in your results, whether you saw changes, after people had their legal intervention. Did they feel more able to tackle some of those other things?
Yeah. Oh, I'm so grateful for all of your questions. Yes is the answer to the last one, most definitely, right? So we interviewed 8 of the families that received services during the first 2 years of the medical legal partnership, and 2 things really came out clearly in the qualitative data. One was that the stress associated with unresolved legal problems made us think that actually unmet legal needs is another social determinant of health, right? But we can't measure that right now. I don't even have any. I mean, there are wonderful stress measures, but there's no study on that in order to make it clear beyond the qualitative studies that we did. And I published it somewhere obscure because I needed to get it out quickly from my promotion. But it was really clear that stress was one of the outcomes. The other thing that was really, really clear was that relieving the stress gave people agency. So I'm going to use the family that we moved out of the bed bug place. We couldn't get them to come to appointments. Their record for appointments was really bad. They were in a federally qualified health clinic. We did a 1-year follow-up because, again, the students were so diligent about this. These guys would take a taxi not to mix an appointment. Right? Son had a disability rating and was actually eligible for employment at this point. So he was coming off of unemployment, off of disability, and while I cannot confirm that he actually got a job, I can confirm that he was interviewing for jobs at that point. That's a big transition, but the real wonderful indicator was one of the things we noticed when we were cleaning off, because you have to swab everything with alcohol, then put it into storage for a certain period of time to make sure it's bed bug free, and then we moved it a second time into their apartment. One of the things we noticed is that they all had art equipment. They were all artists, and they didn't do their art as they were living in these horrific circumstances. Well, one of the gifts they sent to their student lawyer was a small acrylic, and at least Mom's back doing her art. So yeah, I have some anecdotal, qualitative evidence that says it makes a huge life difference.
Wanted to ask a question, Mickey Eater from Minnesota, about the two kind of metrics that you were feeling good about. One is the reduction in hospital stays, and the other is the kind of continuity of care, the continuing to see a physician. And I wonder if you've gone back and looked at the management of chronic conditions in the group that you worked with to see whether longer term there is better outcomes and cost savings as a result of those kinds of changes.
So the answer is I have not, but I certainly will now, because that is a fabulous idea. The good news is that that data set that we had is now transferred to a health policy center in Colorado, and we're working on follow-up studies in order to do the kinds of things that would round out the data. Another thing that turned out to be a problem, and might actually turn out to be a problem in looking at management of chronic conditions, is the variability in the electronic health record keeping that we were using, right? We had, as I said, 202. I mean, they were phenomenal variables. Some of them were social variables about abuse, about cognitive delays, but the record keeping was horrible and the amount of missing data was horrific, right? So one of the things that we could do is go back and look at chronic conditions and then educate providers on how better to keep records so that we could actually do something with the data. When I got access to it, I was thrilled. And when I looked at it, I was really despondent. Thank you.
Hi, Jonathan Tobin, Clinical Directors Network and Rockefeller University. Very inspired presentation. I wonder if you could comment on how medical legal partnerships could contribute to the upstream issue of legislative change in the enforcement capabilities then downstream, so that you might actually put yourselves out of business, hypothetically.
Good, that would be an objective, right? So remember I said we got to do 12 cases a year, and that's because we were only focused on one of the things that medical legal partnerships can do well, and that is direct legal representation. The answer to your question would lie in medical legal partnerships actually doing policy advocacy on issues that are collectively harming populations of people. Payment structure is one, but even a more direct one that we did the last year I was at Colorado was environmental injustices, right? So if you look at a population of people, we were looking at 3 neighborhoods, about 10,000 people in those 3 neighborhoods in North Denver that had been exposed to the injustice of a highway that was planned by the Department of Transportation to expand from 6 to 22 lanes in their neighborhood, right? And that's in addition to an east-west highway, I-25, that already bisects their neighborhood. Add to it that they were a Superfund site, they had smelting plants, they had a landfill in this population. They also, because Colorado legalized recreational marijuana, were a low enough cost place that there were 6 marijuana dispensaries in the neighborhood that students from some parts of the neighborhood had to pass in order to get to the elementary school, right? And they had a railroad too, right? So all of these multiple sources are policy issues that medical legal partnerships could actually address on a policy level. We didn't file it alone. We filed it along with the Sierra Club and Earth Justice, a Title VI suit alleging racial and ethnic discrimination for this population of 10,000 because the highway actually was also proposed in a white wealthy neighborhood which was able to organize and resist. So that kind of policy advocacy could put us out of business if we could look at the very large injustices that are health harming, like environmental injustice. If we could do something about payment reform so that social care and social interventions are covered, but those kinds of policy advocacies would be a better place, I think, for medical legal partnerships to focus than direct legal representation.
Thank you.